The goal of this video is to help you to create new evaluation forms that will be meaningful to both your faculty as well as your trainees, and which will keep you in compliance with being able to report on the ACGME mandated milestones for the next accreditation system. Milestones need to be reported every 6 months beginning December of 2014. Basically, what the ACGME is trying to assure through the next accreditation system, graduates from an approved training program anywhere in the United States will be competent to independently provide high-quality clinical care in that particular specialty. This means that over time, we must entrust our trainees to perform a greater degree of patient care with less supervision. The concept of entrustment is critical because it relates directly to the level of supervision that a trainee requires in order to practice in a safe manner. Determining the level of supervision that a trainee requires is probably the most important responsibility that we as clinician educators in a teaching institution have. There's an inherent tension in our role as educators between granting our trainees progressive autonomy while honoring our patients' and parents' trust that we will provide safe and effective care. We constantly, often subconsciously, make these entrustment decisions when we function as a teaching attending on a busy clinical service. Determining that it is safe for you to see your own patient or to supervise another trainee while one resident or fellow is evaluating another patient means that you trust the trainee to recognize their own limitations and to call you as needed. One of the things that's interesting is how each of the different specialties decided to construct their milestones. As you can see, there's quite a variation in the number of subcompetencies that are listed for different specialties. So some of the specialties, particularly the surgeons, have been more direct in the way they've constructed the subcompetencies and milestones. Therefore, in constructing an evaluation, pediatric orthopedics, it's very straightforward. You can map a couple of subcompetencies. Subcompetencies for both pediatrics and internal medicine are written in a slightly different fashion. These subcompetencies are more generic, such as make informed diagnostic and therapeutic decisions that result in optimal clinical judgment, and the milestones relate to attainment of that more generic subcompetency. So unlike surgical subspecialties, pediatrics and internal medicine need some type of connection between subcompetencies and milestones to the types of patients that we expect our trainees to be able to care for. This concept of professional activities between milestones and subcompetencies, this term was defined by Kate, and I like to think of EPAs essentially as what are the goals in terms of the types of patients that we expect our trainees to be able to care for. They're units of professional practice, routine activities that a physician in that specialty should be able to perform. They can involve tasks and responsibilities that are entrusted to be performed unsupervised. They can be independently executed, observable, and measurable, and they can be sequenced with increasing difficulty, risk, or sophistication. Assessment focuses on the level of supervision that's required. So, for example, in pediatrics, we have taken our rotation-specific goals and translated those into EPAs. Resident rotations are defined by a limited number of EPAs. So the initial tasks are to rewrite resident goals and objectives as rotation-specific EPAs, and then to create an evaluation plan that aligns with the next accreditation system. Our approach for developing our evaluation forms is to think of the evaluation form similar to an antibody. There's a variable portion and a constant portion. The variable portion is where we define our rotation-specific EPAs, and then we add to the constant portion the common subcompetency milestones to create our rotation evaluation form. This slide depicts the different concepts of EPAs, competencies, subcompetencies, milestones, and objectives relate to each other. Remember, the EPA defines the type of patient or professional activity that you expect a trainee to become competent in because of the clinical experiences they're getting on your rotation. These relate to the 6 competencies. Basically, what you do then is look at the sub-competencies that you're required to report on and relate those back through mapping to a particular EPA. Sub-competencies around medical knowledge and patient care relate best to these specific rotation EPAs. Within the sub-competencies, there are the 4 to 5 levels of milestone attainment. And again, I'll show you how these can be linked back to the EPA. Objectives then are used in writing your EPA so that you are sure that all of your objectives for your training program are covered by one or more sub-competencies or EPAs. In this way, we're mapping our curriculum and assessment strategy to the clinical education that we're providing for our trainees.
The steps to constructing rotation-specific faculty evaluations consist of the following. First of all, determine the 5 to 7 rotation-specific EPAs you want to assess, and these are based on the most important goals and objectives for your rotation. Next, determine the leftover common sub-competencies that are appropriate for a faculty member to assess a trainee on during a rotation. Each evaluation form should have less than 15 items. The appropriate sub-competencies to the EPAs. For example, in hospitalist medicine, for pediatric residents, one of the EPAs is to manage patients with acute, common, single organ system diagnosis in an inpatient setting. This particular EPA maps most critically to the patient care subcompetencies 1, 4, and 7, and the medical knowledge 1 subcompetency. The diagnoses that are considered to be most important for the trainee to encounter and to be proficient at are the following 10. This is how the rotation-specific EPAs appear on the evaluation form. As you can see, there are 4 for the hospitalist medicine academic teams. The first is the one I mentioned, manage patients with acute common single system diagnoses in the inpatient setting. The second is to appropriately order supplemental IV fluids. The third is to evaluate and manage patients with undiagnosed chief complaints that are severe enough to require hospitalization, such as failure to thrive and fever without source. And the fourth is to identify, evaluate, and manage potential complications of medically complex and technology-dependent patients. As you can see, you can choose from one of the 5 different levels of mastery. And there are radio buttons in between these 5 levels so that you can choose a 1.5, 2.5, etc. In general, we expect that the level of supervision required for an intern will be different than that of a third-year resident. So we would expect that by the end of the intern's rotation on the hospital service, they would be at a level 2 to 2.5, which means they would need some direct but not complete direct supervision. Whereas for the more medically complex patient, an intern may be 2 level and the senior resident may be at the 3 to 3.5 level. Here's an example of an EPA worksheet, and it demonstrates what we would like you to begin to do for your different specialty rotations. This EPA is entitled Acquire the Imaging Skills Required for All Aspects of Pediatric and Congenital Cardiology Care, taken from the Pediatric Cardiology Specific EPA. The description of the activity is then listed in the box below, and we are suggesting that once you describe your EPA, you can map the sub-competencies, patient care 6 and 7, medical knowledge 1 and 2, systems-based practice 2 and 3, practice-based learning improvement 7, and professionalism 5 and 8, all to the rotation-specific EPA. So if you look at the proposed sub-competencies that need to be reported to the ACGME, we're covering a good number of them with each EPA. The next step in constructing your evaluation form will be to take the starred items here such as provide appropriate role modeling, can identify strengths, deficiencies, and limits in one's knowledge and expertise. So take each of these subsequent 9 subcompetencies and sprinkle them generously over your different rotation evaluation forms so that at least on 1 or 2 forms all of these common subcompetencies are covered. In addition, we are going to create separate generic evaluation forms for handoffs, so for evaluating the quality improvement projects. The Med Ed office will work with you to map your subcompetencies to EPAs